As healthcare moves away from traditional fee-for-service models, providers need a strategy to stay competitive. That's where Strategic Healthcare Partners comes in. We offer expert consulting and ongoing management oversight for providers looking to form an accountable care organization. From financial feasibility analysis to helping you choose the right ACO in a crowded market, SHP provides the clarity you need to make informed decisions and transition to value-based care. Learn more at shpllc.com.
Welcome to Beyond the Stethoscope, Final Conversations with SHP. This is Aaron Higgins. On today's episode, in the headlines, Jason Crosby and I discuss the growing helium crisis for MRIs and how the pool of volunteer health transportation drivers is shrinking at an alarming rate. Are we headed for a great volunteer resignation? Then we continue with part 2 of the interview that Mike Scribner and John Crew had with Aledade CCO and CPO Sean Cavanaugh, where they will wrap up their discussion about value-based care, where it is going, how organizations like Aledade can help, and what this ultimately means for patient care. Are you ready for this vital conversation? Let's get going. Hey there, Jason.
Hey, Aaron. Good morning.
Good morning. How are you doing today?
I'm fine. Thank you. How are you?
Pretty good. Hey, we got some headlines we want to jump into real quick. So let me get to this first one. I think it requires a dramatic reading. So here we go.
The world is running out of helium, and here's why doctors are worried.
Well, liquid helium, as we know, is used in MRI machines, and it's really, really important that we don't lose this vital resource. Ironically, helium is the most abundant element in the entire universe, but because it's lighter than air, it escapes Earth's atmosphere very easily. And we've been using it for the last, 70, 100 years to fill things like balloons, kids' balloons for parties and such. And yet, here it is that we need this for medical equipment, but we're running out. Some of this has to do with the way that we're collecting helium. Some of this has to do with the way that we're drilling for oil. While there's lots of helium out there, even on Earth, getting to it is expensive and difficult. Again, it's super abundant in the rest of the universe, just not here on Earth comparative. So we have a growing problem. In fact, you may start to see where you go to get your kid a balloon for their birthday party, and they won't fill them up with anything other than regular air. So this is a problem. We've known about it now for several years, and it's finally coming to a head. It's going to be interesting to see what we end up doing.
Very interesting article. I did not know that fact. It's interesting to see how supply chains affect even our industry on things like that, isn't it? I mean, very, very interesting. My article actually hit home on a personal basis I came across this week. Had a conversation with a family member a couple of nights ago, lives in a rural area, does not have transportation, and it's getting more difficult for him to reach out to find transportation to go to the Good Samaritan Clinic. Modern Healthcare revealed a shortage of volunteer drivers complicating access to care in rural America that dropped earlier this week. And it points out to basically kind of an economic issue and then a depleting volunteer base who normally takes up such a volunteer that's important, right? And so typically your seniors in a rural area may need help. The volunteers are also kind of an aging population, so that's occurring. But what's also occurring, as what's hurting us all, just kind of inflationary factors, the gas rate, right? So there is a IRS reimbursement rate of 14 cents per mile on charitable rates. Now, if you travel as part of your business, you saw that go up to 62.5 cents just in June. Congress did not increase the volunteer rate at 14 cents. And so if you've got seniors that are being impacted at that rate as well then of course they're not able to go drive further to pick somebody up, take them to their appointments and such. And so you're having areas in various parts of the country that the volunteer base is is being reduced by the aging population, and now there's this economic impact. And so folks in need to get to their provider are subsequently impacted by this. And I think that's something I just myself wasn't aware of and found it very intriguing this week. And so that's my news for the week.
And that sounds like a problem. We're feeling the pinch everywhere, the great resignation and now the great volunteer resignation. Alrighty, Jason, I know that wraps us up for news. What guest do we have today?
Today is part 2 of the Sean Cavanaugh interview. Again, Sean is with Aledade, formerly with CMS. You're going to hear a lot more about various impacts on our providers with value-based care, what Aledade's doing in the market, and simply steps you can take to improve your independent practice. Very intriguing part 2 interview with Sean.
Okay, looking forward to it. We'll talk to you next week.
Great. Thanks a lot, Aaron.
It seems like to me, and maybe you can touch on this, there's a very distinct difference between the traditional Medicare patient here at White Blue and the MA population. And what I mean by that is MA sort of varies from state to state in terms of how it's covered, how maybe a Part D is wrapped in Part B and others. Can you share just a little bit from your perspective, the difference in the two models and in what, if anything, is different for the physician to be successful in those things and the MA side?
Yeah, as you said, MA is growing rapidly. It's a competitive market with you tend to have 4 or 5 big national companies and then often a long tail of smaller plans locally. Within a market, you tend to see a convergence on the types of benefits being offered, but they can vary from market to market. What we've told our practices is working with Aledade, you might have 3 or 4 MA value-based contracts, but the STARS rating quality measures are going to be the same across all of them. So you're trying to do the same quality care. As you said, the populations can be somewhat different. You know, what is attractive about MA? MA is good for people who need financial protection, who are willing to work within a defined network of providers, but don't have a lot of money out of pocket and specifically can't afford a Medicare supplemental policy. So you do see often lower income communities gravitating toward that product. But, you know, as we approach 50% of the Medicare population, and if it keeps going north of that, the differences, you know, will not be that stark. It'll be more like the Medicare population as a whole. But we do see that particularly in certain regions of the country.
You know, you touched on something there that really is a challenge for providers as we talk to them. You mentioned those that are coming into the market building the MA platforms, and there seems to be an awful lot of VC-funded organizations that are coming in, and there is, to your point, there's those that are known, and that there's a lot that's unknown. The one thing that seems to be a prevailing model as in terms of exposure for physicians are these that come in, they're either looking to build a model and sell it to someone else, or they're looking to maybe build it and go public. Either way, there's this natural instinct from providers thinking everything's a short-term relationship. Can you sort of talk to that a minute?
Yeah, I think what you're getting at is because MA is growing so much and because the big companies are, you know, longstanding, you know, legacy companies like United and Aetna, there's a perception that there's an opportunity for smarter startups to come in and beat them at this business. It's like a lot of businesses. You see some really cool, interesting ones, and you see some that you roll your eyes at. And I worry about the ones we roll our eyes at, because as you said, Medicare Advantage can be so lucrative. You know, you could start a business, enroll a bunch of people, and just sell the company and probably get rich. You know, at Aledade, we're pretty wary about doing business with them. What you're also seeing, though, is some separation of the wheat from the chaff. Like those same companies that looked at United and said, look at that big, dumb legacy company, are learning that United's not so dumb, and there's a reason they got big, right? Maybe we don't all support the reasons they got big, but they know what they're doing, and beating them at their own game is harder than it looks. But you do see some promising ones. One we've known for a while, for example, is a plan that's small but growing called Devoted Health. And I think they have the right values and are in it for the long haul. They could have sold probably, they could be rich by now if they needed to. But they seem to be in it for the long haul. They didn't suffer. Last year, a bunch of them, the startups that went public suffered tremendously in the stock market. So I think over time, you'll see, you'll be able to separate the good from the bad, and there will be some good ones. But we are very careful who we do work with for that reason. Like, it's not good for the patient if they're churning through plans. What they need is a long, stable relationship, because the challenge with the seniors is managing multiple chronic diseases over, the course of their life. And so hopefully the most stable thing in their life is the relationship with their PCP.
Thank you so much. To piggyback off of that question, one of the things that we're being exposed to for providers that are in value-based medicine and excelling in value-based medicine, we are now seeing some of these companies who are beginning to come in regionally and try to pick up the best of the best in each of the areas that they're located in and build a new model that's, that is all with successful value-based providers using benchmarks from other areas as a way to appeal to them. So they're beginning to have, instead of having a organization that was built and sustainable, you're having those trying to pick it apart, take the best out of it, and build another one. Do you see that as being a problem long-term?
Potentially. As I said, that's certainly not the Aledade approach. Aledade approach is everybody who wants to do better by their patients can probably get better. The other thing I would say is the limitation of that approach is the big plans aren't looking for narrow networks in MA, because that's not consistent with growing their membership. So narrow networks have been popular, like in some of the ACA exchange marketplaces where people are paying out of their own pocket. In some niche markets like that, and not that that's so niche, it has a lot of people, but in MA, even though people are choosing the product themselves, people are not looking for narrow networks. And so I don't think that approach will have a long life in MA unless something changes that we haven't seen yet. But there are places for narrow network high performers, but it often gets more talk than reality.
Sean, not to kind of cut a hard left in the discussion, but I guess I want to spend the last few minutes kind of talking about, from a CMS perspective in general, what do you think is the future of value-based care from their perspective, and where's the Innovation Institute going, those kinds of things? Can you talk a little bit about that?
Yeah, I think this group at CMS and the administration more broadly, they spent a good part of their first year trying to put out a roadmap and a statement of values. And I think the important things they said were two things. One, we believe in value-based care, and we have a goal by 2030 of getting everybody in Medicare and value-based care of some sort. And they were a little vague on what that meant, but I think what it means is get out of the traditional fee-for-service world where people are just paid to produce services, and get them into a relationship with someone who cares about the total experience of care, both the cost and the quality. MSSPs being the largest example of that, but there's some other CMS models that would mean. So that was the first thing they said. Not really that new, right? The Obama administration said that, the Trump administration said that, maybe not in the same words, but said something similar. The thing they said that was different, though, and that's, gotten a lot of attention across the country, is a greater emphasis on health equity. So not leaving some populations behind, whether it's in value-based care or anything else, or in access to care. And so I think that's what you'll consistently see in every action they do, is how do we get more people into these models, and how do we design these models so providers sign up lower income people, providers improve care for lower income people, or any community that hasn't gotten the highest quality of care in the past. I think both of those are incredibly laudable goals, and we support them. They're also very difficult goals. One, value-based care, which we've dived into wholeheartedly, but, it's been a voluntary program. How far can you get in voluntary programs? We'll find out. And in health equity, first of all, we will not make any progress unless they were shining a light on it, unless they're designing new programs around it. So more power to them. But we also know it's hard. Aledade's been committed to this over the past year. We've been focusing on hypertension among African-American patients because our founder, Farzad Mostashari, says that's where we can save the most lives. And so we've made some improvements, but it's been hard. And the physicians love it. Like they love making a difference in their communities, but it is hard work. So I think you'll see those two themes in whatever form, whatever they're doing out of the administration, those will be the themes, whether they're working in traditional Medicare or MA, which are from a policymaker's perspective, two very different environments, but they'll be pursuing the same goals.
I don't want to throw a curve here, so bear that in mind as I ask this question. So, I appreciate that your expertise has been in the Medicare side. What we're experiencing in the various markets, you're seeing the transition of Medicaid going into value-based models. So have you guys experienced any of the Medicaid transition models going into value-based? And if so, can you talk a little bit about what the challenges of Medicaid value-based is versus Medicare?
Yeah. Oh, I'm so glad you asked, John, because we've got, I think, 150,000 Medicaid lives in risk contracts, value-based contracts. And this came about because we started working with federally qualified health centers in a couple markets in a big way. And we started working with them for Medicare, but they quickly said, hey, we've got all these Medicaid patients. So we have a relationship with a couple plans where we're taking risks from Medicaid. We're really happy and proud to be in the space, but it's a learning experience. One of the things you find is, someone gets on Medicare, they're on Medicare for the rest of their life. So they may move through fee-for-service, go into an MA plan, but they're in Medicare. The Medicaid population, there's much more churning. There's less of a traditional attachment to a provider. So, Medicare patients tend to have, if anything, too many physicians, where in the Medicaid population, many of them don't have a usual source of care. So you're trying to establish that. And then just the clinical differences of, Medicare population, what they're dealing with are, as the management of multiple chronic diseases over a longitudinal period of time, where in Medicaid, you're dealing with a lot of moms, a lot of kids, some single adults, and then the expansion population. But just clinically, the interventions are different. But the good news is if you take a step back, some of the stuff they need is the same thing. They need someone who's got a 360-degree view of their health, what's happening to them, someone who's looking at the data, seeing when they're in crisis and reaching out to them and wrapping them in the arms of primary care, someone who's accountable for their experience of care, their total cost of care, and the quality that they receive. So the needs are the same. The tools have to be adapted. I'll give you an example. Like in Medicare, we target what we call high priority patients for annual wellness visits. Well, deciding which senior needs to come in for an annual wellness visit is very different than deciding which 6-year-old child needs to come in for a wellness visit. So our clinicians, our statisticians have been working on that. And so that the intelligence works its way into our tools over time. But it is a new space, John. You're right. Like we don't see a lot of other organizations rushing to take Medicaid risk. We felt like, one, we had to service our partners or the federally qualified health centers. If this is important to them, it's important to us. But also, these folks need value-based care too. So we're going to be a provider of it.
We're coming to the end. I have one quick question, sort of relates to that, both the care and the CAID models. States varied by, or health insurers, let me get back at least, varied by what models they have. For example, in Georgia, we used to have a lot of gatekeeper models, and we no longer have that. Is it more challenging coming into a state where products are sold that don't require gatekeepers?
Yeah, we get that question a lot. Like, how are you going to control costs? There's no gatekeepers. And we remind people, we learned this business in traditional Medicare, which is the ultimate PPO, right? Like there's no gatekeeping at all. What I remind people is there was a backlash to the gatekeeper models throughout the whole country. And people gave up on that for a while with good reason, because it was used as a pretty blunt instrument. I think you can get a lot done with, with your PCP being the gatekeeper, your PCP who has your best interests in mind. And it's not like a regulatory or contractual gatekeeper. It's more of a quarterback. I'm here to get the best thing for you, and spending more money isn't always the best thing. So yeah, we're not worried when there's no gatekeeper. You know, that's where we learned how to do this. Yeah, you can save some money that way, but you can get better care another way through better PCP, you know, better primary care.
Great answer. Thank you, Sean. We really appreciate it. That was great.
It was great talking to you guys.
You've been listening to Beyond the Stethoscope, Vital Conversations with SHP. This has been a production of Strategic Healthcare Partners. Your news hosts today were Jason Crosby and me, Aaron Higgins. It is produced and edited by Nyla Wiebe. Our social media content producers are Nyla Wiebe and Jeremy Miller. And our executive producers are Mike Scribner and John Crew. For more information about SHP and the services we offer, including the back library of episodes, episode transcripts, links to resources discussed, and much, much more, please visit our website at shpllc.com. Thanks for listening. You already know that understanding your data is key to improving patient outcomes and financial performance. But how? At Strategic Healthcare Partners, our analytics services help turn your EMR and other data sources into actionable insights. From identifying areas for improvement to guiding you through implementing changes, SHP supports you every step of the way. Our performance analytics service dives even deeper, providing custom reports that help you stay ahead in the transition to value-based care. Unlock your data's full potential with SHP. Learn more at shpllc.com.